Hey, good morning. This is Steve Stites, Chief Medical Officer here at the University of Kansas Health System. Delighted to be back with you on this beautiful, sunny, is it Wednesday morning? It's Wednesday morning, right? Wednesday morning. And we have a great program here for you today. Of course, Hawkeye is back with us today. And Dr. Catherine Satterwhite. Catherine Satterwhite is a PhD. She's working now for Health and Human Services. She was elected multiple times as our best educator here at the University of Kansas when she was a faculty member. And then she had a calling to go over to HHS. She is the regional director. We're looking forward to visiting with you in just a few minutes. Yeah, that'll be a great discussion. We have lots to talk about today, I think. But first, Hawkeye, how are you doing?
She really classes up the show, so that helps.
Well, come on. You and I, it's not hard. Set the bar low here, brother.
It's a low bar. We're doing pretty good in numbers. Yesterday we had said that, we had gone up, 50% from 8 to 12 active inpatients. Today we have 13 active inpatients, 5 in the ICU, 2 on the ventilator, but only 7 in that recovery period, so a total of 20 patients.
That is so much less than we used to have.
Yeah.
That's 10% of what we once did, so
great.
That's really great, isn't it? Yeah.
Hopefully we can keep those numbers low. Hayes is still doing better, just 2 active patients in the hospital as well, so that's good to hear.
So something's going right out there, because despite what we read, we hear this, we hear that, the reality is hospitalizations are the one thing that we know are true.
Yeah.
And we don't have to worry about testing or anything. We just need to know how many people are here and who are sick. So that is a pretty good thing. From the very beginning of this pandemic, we said that we are building the airplane while flying it. This has included everything from the therapies for treating COVID-19 as well as vaccines. So today we're going to show you a very special video from the Jimmy Fallon Show. But before we go there, we're going to see if there are reporter questions out there.
You're going to lead with that and make me follow a Jimmy Fallon video?
No, I'm going to make you go first, so you don't have to follow the Jimmy Fallon video.
Oh, well, thanks a lot, guys. Cody from Channel 9 here. As we talk, and it's good thing Dr. Satterwhite's here, too. I'm curious, as we continue to get viewer questions about the Johnson & Johnson announcement, are you concerned? I'm sure the answer is yes, but if you could elaborate on people's fears about overall the whole vaccination process for SARS-CoV-2 and the potential threat of, the character being diminished of Pfizer and Moderna. And also for Dr. Satterwhite after that, I'm curious how this affects the rollout. I'm still getting tons of questions about that here at the station.
So I'm going to start first, Hawkeye. I think it's no question we're concerned about the pause on the J&J vaccine and what that's going to mean to Pfizer and Moderna. I was listening on the way into NPR, and there was a conversation with the former head of the FDA, and just the comment that we may top out at 160 million doses of 330 million.
Yeah.
That's not enough. Now, we know we've got a lot of people who have been vaccinated, and we can feel it here, what a remarkable improvement that has been. But when we only have 160 million people, and then you're relying on just people who've had the infection to help achieve immunity, at some point, their immunity wanes. They're going to have to get in line for a vaccine if we're going to do good. And finally, if you're not vaccinated, it's not clear that you can't still get the variant, and you may then develop more variants.
Yeah, absolutely. The more susceptible people out there, the more the virus does have those chance to mutate and replicate and cause those variants. But we need to also look at what is the narrative of this. So, yes, we did that pause because of 6 cases and almost 7 million doses. So, but what if that didn't happen? Then there would be even more reluctance from the general population, the general public, to accept these vaccines if it came out that this was known but nothing was done about it. So also understand that those adverse events, what was it? 1 per 1 million, basically, 6 cases and almost 7 million. How many people in that age group of which those side effects occurred, that 18 to 48 in those blood clot age group, how many people died? And that was about 125, 130 people per million. So still, the vaccine has a lower risk of having that complex or adverse event than actually getting COVID. So that is important to note. But we do need all of these vaccine candidates. We have Johnson & Johnson. We know that they significantly reduce your risk, your whole spectrum of disease, really, from just being symptomatic, of course, to hospitalization, severe disease, and death. And we certainly hope that as time goes on, we can still see an emergency use application for the Novavax vaccine, because that data looks good, and possibly even AstraZeneca, because that is being rolled out around the world as well.
So let's see, Catherine, what are your thoughts around this? Because I know HHS has been intimately involved in some of these questions.
Right. So I think there's a couple points to highlight here. First, that CDC, HHS, and this administration overall are really committed to transparency. So even though in some senses this is a little bit complicated to cover in terms of messaging, it is something that we wanted to make people aware of because of this transparency. It is also true that COVID-19 vaccines are safe and effective. That has not changed. These vaccines are being very, very closely watched. There are a number of mechanisms in place to catch just these kind of very, very rare events, which I know has been talked about on this show in the past. Even yesterday, I know you guys talked about that a little bit. And to get to the second question that you asked, the proportion of vaccines that our states in this area are getting, Kansas and Missouri included, that was Johnson & Johnson is relatively small. So most of the vaccines that are coming into all states actually are still Moderna and Pfizer. So while this pause does certainly impact vaccine rollout in terms of just numbers and logistics, there are still a lot of Moderna and Pfizer vaccines available, and all of our states are really committed to helping people reschedule if they were originally planning to get that Johnson & Johnson vaccine. So the overall impact from a logistics perspective is actually not huge. From a really messaging and confidence perspective, that's I think where we need to be focused.
Yeah, it feels this way. It's 1,000,000 to 1. That's the odds right now that you're going to have one of the cerebral vascular thrombosis that has been seen in patients with the J&J vaccine and with some of the AstraZeneca worldwide. Mm-hmm. That is a very low number. Now, let's think about what your odds are with bad outcomes with COVID. It's a lot, the odds are much worse than 1,000,000 to 1, right? And to also say that those of you who think, well, I'm young, I'm not going to get sick, or I'm not going to get hospitalized. You know, this long COVID deal is a bad deal, and we've spent a lot of time talking about it. And remember that you can get long COVID whether you're young or not. Whether you, in fact, more information coming about kids with the inflammatory process after COVID, and you may be asymptomatic with COVID and get long COVID syndrome. So it's not related to how sick you were in the hospital. So you have to see it and think, gosh, the vaccinations are not only my way of stopping getting COVID, but also the long-term complications of COVID-19, Hawk.
Yeah. No, I mean, I totally agree. Like we said, you know, in that age group, 18 to 48, there's been 125 or 130 deaths per million as compared to the people who got the vaccine in that 1 in a million. So your risks are definitely higher with the disease.
And to say that about 130 million people get the flu vaccine every year. And so if we're at 160 million of people getting the COVID-19, that's better than the flu. Mm-hmm. But this is so much worse than the flu, right? We've had over almost 700,000 deaths from COVID-19, and we have maybe 30,000 or 40,000 in a bad year dying from influenza. Yeah. So there is no question how much worse COVID-19 is. You should want this vaccination, I
Absolutely. And I just want to make one follow-up comment. So first of all, yes, please, if you haven't gotten vaccinated, and I'm sure I'll say this several times, if you haven't gotten vaccinated, please consider getting vaccinated and certainly look for that information that you need to be confident in that decision. But to go back to the question that was originally asked too about Johnson & Johnson, so it's important to remember this is a pause. This is not a stop forever. What we're asking states to do is just hold on to their supply while we go through this very important process of evaluating what has been raised yesterday with these 6 cases. So the Advisory Committee on Immunization Practices is meeting today at 12:30. It is open to the public. If you wanted to watch it, you could certainly go to, you could Google CDC ACIP, and it'll get you there, and you can watch and hear what they're talking about. Again, transparency. The FDA is likewise going to be reviewing these things. So this pause, really, I think we don't anticipate it's going to be very long. So we're asking people to hold their supply and just await further guidance.
In fact, what I think we keep hearing is that it's going to be just several days while we figure out how we're going to approach this. And so in Europe with the AstraZeneca vaccine, they said, I think in a number of countries, that only for those who are older, where they didn't see the clotting issue, as opposed to those who are younger. Do you foresee anything like that here, guys?
What do you think?
Yeah, I mean, I would totally agree. I think that's a great point you brought up. And we don't want to get too much into AstraZeneca versus Johnson & Johnson because we don't use AstraZeneca here. But it's hard not to draw those correlations. Same type of delivery system and payload with the virus vector and all that. So I think it's important to understand that and note that. And really, to your point, that is excellent, because we have to understand it is a pause, and they are just trying to deep dive and to get all the medical details. We get questions all the time here on the update, and a lot of our answers is we can't really answer some of those questions because we don't know all the details. That's what this pause is for, to really do a deep investigation into all of those details.
And importantly, one of the key things about this pause is to make sure that medical professionals have the cues and know how to treat this should it arise. That's one of the really important things that I've heard emphasized.
You know, I think you should feel in some way comforted by the pause. Now, I don't mean that because that seems kind of goofy,
No.
right? But I do mean it, because here's the thing. We do a really good job of surveillance in the United States. That's why the FDA, even though people get upset that it takes too long to get things through, but the FDA is the gold standard around the world for drug approval and drug and safety and efficacy. And so what you're seeing is our protections in action to make sure that you are safe. Frankly, any drug that has a 1 in a million side effect, knowing that the disease is so much worse than the drug, or than that side effect overall, that's going to get through the FDA, right? That's going to get approved. If the odds really are only 1 in a million, you'll have guidance. You'll have guidance because there is effective therapy for this. IVIG is the therapy for it. It's not heparin. It appears to be effective in most cases. It's cerebral vascular thrombosis, which is caused by essentially something we're very familiar with, idiopathic thrombocytopenic purpura, ITP. And that's a lot of words, but what it really says is your platelets are globbing together too fast, and when they do that, your platelet count drops, and when it drops, it means that you can bleed more easily. So the therapy is to give IVIG, which tends to work in ITP. And if that's the case for vaccine-caused ITP, even at a 1 in a million, we now know what we need to do. So my bet is the J&J vaccine, like the AstraZeneca vaccine, is still going to be out there. We're still going to be trying to use it. And I think that so far, not a lot of proof that, or not any evidence that Moderna and Pfizer are causing the ITP. But the ITP is also very rare. And there are some populations for whom one shot is a tremendous advantage. And I think I think we're going to still see the J&J vaccine as being part of our armamentarium. And I hope that it is. So anyway, other questions out there?
You mentioned the other communities, and a quick follow-up. One of the benefits of J&J, as you guys have said for months, is that it doesn't require the ultra-cold storage, can go to more rural areas. Is there a concern now about vaccination upkeep or uptake in those types of communities?
Absolutely. I'm concerned this is going to be, a damper on what we need to do. And we'll have to watch that effect over time, but anytime you see these kind of things, it takes a while for the public to recover.
Well, and I think there's two pieces to this. So again, if we think about logistics and availability, so you mentioned ultra-cold storage. So Moderna is still also very good for rural areas, and they have even more temperature flexibility than they had in the past. So we're seeing a continued research to figure out temperature stability and how things can be stored. So Moderna is still largely being sent to many, many rural areas in the Midwest. So I don't think that supply will be an issue. You're right, it does require 2 shots. It's not as easy as the one and done, which is what we've heard a lot, that there are a lot of people who really, that appealed to them. They really wanted and sought out Johnson & Johnson. But again, we've had a pretty limited supply of Johnson & Johnson up to this point anyway. Yeah. So rural areas should still have vaccine available because I think Moderna has largely been that primary source for them even before Johnson & Johnson was granted an EUA.
And just to say, if you looked at the demand curve and the supply curve here in the last, we're right in the midst of it, but it's shifting. We now have more supply than we have demand.
Absolutely.
And that scares me a little bit because I don't want to say that, but it is true because it means that people aren't getting vaccinated. If people aren't getting vaccinated, we're going to have a hard time getting to herd immunity, which means we're going to have a harder time getting all the way back to normal. And, I want to be in front of 78,000 people screaming my lungs out at the Chiefs game this fall.
Yeah, I think, and this is true for all new vaccines. So COVID-19 is, an unprecedented event, and we've had this tremendous, exciting progress to get these vaccines to where they are today. But this is not the first time that we've had a new vaccine. And oftentimes what we see is many people very excited and very interested in getting a vaccine, and then we get to this point really kind of where we are in many parts. Some urban areas, I will say, some urban areas still have that supply is less than demand, but a lot of places are supply greater than demand. And we're going to get there, urban areas, if we aren't very quickly. But the next stage is always, from a public health perspective, from a medical perspective, it's a little bit harder because now you have to really have more conversations. You have to address a lot of concerns. So it doesn't roll out as fast. So the good news is it's going to be easier to get. The bad news is that we're now starting to talk to more people who have a lot of really important questions that they want answered.
Other questions? All right.
Hey guys, good morning. It's Taylor, Channel 41.
Hey, Taylor.
Taylor.
I had a question about second vaccine, and as more people become "quote unquote" fully vaccinated and potentially head back to work, some of the small businesses around here that may have 10 to 12 employees tops and have not been able to operate. What's the latest guidelines on once they're all able to say, yes, I am fully vaccinated, I've had my second shot, it's been 2 weeks after that, being able to work in close proximity to 10 or 12 other people that have all been vaccinated again? Are there updated guidelines right now on people being able to go back to work in those small business settings once they've been fully vaccinated?
Great question. Great question, Taylor. Hawk, what do you
That
think?
is a great question, because one of the caveats of that updated guidance for vaccinated persons is it's in social situations. It's not in workplace situations. So there is no guidance as of yet, Taylor.
However, there is no guidance published, but it is something that CDC is actively looking at.
Yep. And we talk about it here at the health system, and I know other employers are talking about it because it is important. Just for those reasons that you mentioned, people want to get back to work. But hopefully, and again, these things are coming in a conservative, stepwise manner so that we don't take steps back. Nobody wants to shut down again. Our community does not want to be like Michigan is right now, like LA County was, like Detroit was, New York, all those things. So I think it's okay to take that conservative approach. But just as you said, there are strides being made towards getting further guidance for those certain situations.
Speculation. What do you think? Where do you think we'll land, Hawk?
It's hard to say. I think it depends what the employment area is. Is it the service industry? Is it healthcare? Is it something else? I think eventually we will get down to probably no masking in those types of situations, but I think we definitely need a higher percentage of the population vaccinated. Yeah. And we also need to see the data and what is the transmission. We know that there is a multi-university 12,000 person study that is being enrolled right now to look at that exact question. If you are vaccinated, can you still spread the disease? Right now there is signal that you have less ability to spread the disease, but this is a large trial that is actually looking at to answer that question. So hopefully that will provide answers.
Yeah, and I
too.
think some of the preliminary data out of Israel and other areas is suggesting that if you've been vaccinated, and it looks like it's a markedly reduced spread. Mm-hmm. I think that we're going to start seeing that you can begin to open up, but I think size is going to matter. I think who's coming in and out of the building is going to matter. I think ventilation is going to matter. Yep. And I think in healthcare we're going to be masking for quite a while. The thoughts that you have,
No.
I know you can't really speculate. Right. I'm the speculator in chief. That's my role. Okay. Other questions? All right. So we're even today. We're talking about we're still building the airplane while we fly it, and we've learned a lot along the way. But sometimes there's stuff we do know, sometimes we don't know, and what we do know is that the vaccines really do work. Jimmy Fallon is going to take a swing at this about how some of the general public feels in this take from the Tonight Show. Let's take a look.
First, we thought we'd all be vaccinated when September ends, but now it's gonna be May. Everyone's so excited. They're like, it's a party in the USA. But the CDC says we still need to play it safe for a couple months. They're like,
stop, collaborate, and listen.
But everyone's too pumped up. They're like,
I wanna dance with somebody.
But now the CDC is rushing the vaccine. They're like,
Give it away, give it away, give it away now.
But the one thing we can all agree on is,
It's the final countdown.
Wait a minute. Can we play that again? I think we got to play that again. I missed the first part. Some of the songs I didn't quite get. We got to play it again.
first we thought we'd all be vaccinated when September ends, but now
It's gonna be May.
everyone's so excited. They're like,
It's a party in the USA.
But the CDC says we still need to play it safe for a couple months. They're like,
Stop, collaborate, and listen.
but everyone's too pumped up. They're like,
I wanna dance with somebody.
but now the CDC is rushing the vaccine. They're like,
Give it away, give it away, give it away now.
but the one thing we can all agree on is
It's the final countdown.
That is pretty funny.
I love it so much. I swear I watched it like 10 times when I saw it.
Well, now you've watched it a dozen.
Yeah.
That's really good. Well, I wish it was the final countdown so we can all kind of like, celebrate. I can do it too,
Yeah.
Catherine, I think a lot of our viewers identify with Jimmy Fallon. Well, those of us that are here in the medical field and better understand the evolution of research and medicine, including the vaccine rollout, we tend to take things a little bit more in stride, especially the bumps. We already talked a little bit about the pause in the J&J vaccine. Overall, how do you and how do the folks at the HHS feel about the rollout here in the metropolitan area and about vaccination rates in Kansas and Missouri?
So I think this goes back to a comment that I had before in that we've gotten vaccine to the people who were really clamoring for it. So I don't know if I've talked about this before. So we think of vaccine uptake and vaccine hesitancy on a continuum, where on one side of the arrow we have people, the demand is now. They want it now, they are confident, and we can't get it to them fast enough. Those people have gotten vaccinated. So now we're in actually this middle part, which is where a lot of people are. And it's not that they don't want the vaccine, it's that they have questions or they need a little bit more evidence. And we've already seen some populations really from this sort of middle area go ahead and start getting vaccinated. A really good example is some staff in healthcare settings or in some nursing home settings who didn't want the vaccine right away. They needed to see even just a month or two of what it looked like after the residents of a facility or some of their other colleagues got that vaccine. And now we've seen a lot greater uptake. So I think we're pretty pleased with how things are going. I think we are at this very critical point where it is going to be harder. So I think there's a lot to be seen. Certainly the J&J news impacts all of this. But our states, the 4 states that I cover, Kansas, Missouri, Iowa, Nebraska, are really doing an outstanding job. There are just these tremendous partnerships. But yes, it is bumpy. I think even though we said that in the beginning, that we knew it was going to be bumpy, that we knew there were going to be fits and starts, and it was just going to be a challenge at times. It's still a surprise when it happens. And I think it's a surprise to us. It's a surprise to the public and to all the stakeholders that we have involved.
It is. It is going to be a bumpy time, I think. And we just need to get everybody vaccinated. We know how much safer that's going to make us. We're like at 12,000 doses here we still have. We've given, we're going to be over 100,000 doses before in a wink of an eye here. But we're close to 12,000 doses. We want to give a lot of doses out. We don't quite have enough people to take all those doses. What else can we do to get the message out that we want to have people come get the doses and it's safe to do it?
So one of the major strategies that we talk about at HHS and CDC is this shared stories. So we can talk to people about the evidence. We can talk to people about how safe these vaccines are and that they work. But sometimes what people want to hear is from somebody who is like them in some way, maybe as a part of their community, maybe as a part of their workplace, maybe as a parent at their kid's school. There are lots of opportunities, but what we're really looking at doing from the government's perspective is trying to empower local leaders to really address the concerns within their communities and networks. There's actually a COVID-19 core, community core, that has been rolled out recently. And anything I mention, we can certainly get back to you guys with links, but it's an opportunity for community members to sign up to sort of be part of a group that has really good access to information. It's information the public has too, but to be part of a group that is leader in their community to really talk about the benefits in vaccine and why we need to get vaccinated.
That is so important, isn't it? So, do you think that and I'm going to draw a correlation here, lots of concerns in certain communities of color about historical and institutionalized racism, and now the rise and the videos around young men, especially African American men, being shot by police, et cetera. Do you think that's going to make it harder for people in communities of color to get vaccinated?
So, yes, I think there have been healthcare equity issues for a long time, and that some of those efforts have been built over years, both in terms of the damage and in terms of how we're trying to repair and address those situations. It's 2 steps forward, 1 step back. And unfortunately, a lot of those things are very fragile, and they need a lot of attention. So we are worried that populations of people, especially people who have really been hugely impacted by COVID-19, this may really impact, a lot of what you're talking about may impact trust and confidence in a lot of things around COVID-19, but certainly vaccination.
Yeah, and I would just say, I think that wherever, and I'm not trying to say one side's right or wrong, I don't mean that, because we'll stay in our lane here, but it is a public health concern, and that's where we are, that when people lose faith in institutions, whether they're governmental, educational, it doesn't matter. When you lose faith in an institution, you tend not to believe the things, and then you begin to you question it overall, and I'm a little nervous about that here, that we're seeing more hesitancy than I would like. Around the vaccine. The idea that we're in mid-April and we have more vaccine than we have arms, that's just disquieting to me. I think we need to figure out how to turn that around. You mentioned that Moderna may be able to, I'm going to talk to you both about this. Moderna temperature guidance is different. So talk to us a little bit about that. What is that temperature guidance now? And do you foresee a time when we can get, because I'm going to go with this, the vaccine can be given then in physician offices, because I think there's pretty good evidence out there that patients believe their doctor more than anyone. And so if we could get vaccine into an office, all offices, then doctors can give it, whether you're the dermatologist, the pulmonologist, or your primary care doctor.
Right. So you brought up a whole bunch of things that are really important.
So let's talk with, first of all, Moderna and the temperature guidance.
You might know this better than I do, but the big thing is that the guidance and acceptability of temperature storage and length that it can be outside has expanded.
That's it, yeah.
Yeah. Do you know?
I don't know the full details, but I think major key thing that came out a few weeks ago was that it is that expanded time frame outside of that super cold.
Yeah.
Yeah, which I think that this actually ties into your next point too. Getting vaccines into settings where people can talk to their doctor about their individual questions is a priority. There are actually two places. So the federal government has a number of distribution channels that they go through. So probably the one that most people are familiar with is the pharmacy program, the federal retail pharmacy program, which is awesome. Allows us to get back to really work on access. So, a large proportion of the population of the country lives relatively close to a pharmacy. So that program has been rapidly expanding. Another program they have is getting it to community health centers, which we also know are great. And it starts to get at that. People can have conversations with someone they trust. But then the next step that we're working on now is actually emergency room access, which we'll have to see how that impacts with J&J availability changing, and primary care providers. Yeah. And there are a number of things around sort of getting that to people. Moderna is really well suited for that. So we'll have to see, but that is a priority because I think you're right. We have to facilitate those conversations because I think we all know that really the number one predictor of whether somebody gets vaccinated is if their trusted medical provider recommends it for them.
And I think that's key. And I think one of the things I look forward to with the Novavax vaccine, should it be approved, is I think it doesn't have a lot of temperature requirements, as I recall. And if that's true, then that's another way to get it in physician offices. So, all right, Jill.
Lots of questions. All right, I'm going to start with Michelle. There's a lot of people on the thread that are talking about, but these vaccines were rushed. There hasn't been enough study. It usually takes 10 to 14 years before a vaccine is approved. And so can you just speak to, were these vaccines, are they considered rushed?
Yeah, they're not rushed. No. The mRNA vaccines has been around for over a decade. They're not rushed. So you say 10 to 14 years. Okay, well, they've been over here more than 10 years. And so I don't think they're rushed. And the second thing is I would point to the data around Moderna and Pfizer, which show incredible success with very few side effects. And even the J&J, 1 in a million, that's nothing. I mean, there are vaccines with a lot more side effects than that, and people don't get all excited about taking them. So I think what we have to say is it may feel rushed, But it's only rushed because you don't know the history of mRNA vaccination. The second thing is drug development in all spheres, not just vaccination, has accelerated because our vaccine and our science, our science around that is so much better than it once was. You look at CAR T therapy. You can say, well, that's rushed. Well, no, not really. It's just we're much more sophisticated than we once were.
Yeah, I mean, I have two words for that: money and resources. You know, again, not a new platform, mRNA, but even other vaccines, not a new platform. They were trying to develop a universal vaccine for SARS and a specific vaccine for SARS, but what happened? It died out, so nobody cared about it. Resources dried up. They are still looking at developing a vaccine for MERS, but MERS infects probably only a handful of people every year on the Arabian Peninsula. There are other viruses, Zika. Zika was very hot for a little bit, but then died down. And so there wasn't that need. There wasn't the need for the world to put resources and money behind expediting these trials. We have to understand that when you develop a drug or a vaccine, it takes a lot of money and resources. And so you need those money and resources to do that. Well, when you have the entire world backing this one topic, providing resources, providing the great minds to do this, you can expedite that, and you can still expedite it in a safe manner. And we saw that because we had tens of thousands of people in these vaccine trials, which is still a lot more than most drugs or most vaccines do anyway. So I think it's just the need and also the resources that we'll put behind this, but it wasn't rushed by any means.
And it's not over. So I think it's important to remember that these vaccines didn't just stop these vaccine trials didn't just stop when they submitted data to the FDA for their emergency use authorization. They are still monitoring people. So we're still looking for longer term outcomes. There are many studies that are still looking at efficacy in different situations. We've talked about asymptomatic spread. Can you spread the virus when you don't have any symptoms? So these are going to be going on for years still. So it's really, it's a continuum and not just a one and done.
Yeah, and here's what I would also say when you think about being rushed. Remember that it feels rushed because a year ago, up until a little over a year ago now, COVID-19 wasn't on anybody's radar screen, not really. It took 14 or 15 months ago it started. So you can say, well, gosh, there was no vaccine development prior to that. Well, but vaccine research, vaccine science happens every year. The messenger RNA vehicle has been underdeveloped for over a decade. The same thing has been true about some of the protein vehicles we're going to start seeing coming out with the Novavax. The adenovirus vector for Johnson & Johnson and AstraZeneca, that's an old idea. So yeah, I think what you have to understand is that in science, it took a long time to get the messenger RNA vehicle developed, and then they put the spike protein into the messenger RNA vehicle. So it's not like that all got rushed. It really didn't get rushed. It's being out there for a long time and developed in labs and then tested in different models and then had been tested in some people with some of the other vaccines that Hawkeye mentioned. So it's not really rushed. And the reason that you could say, well, it had an early use authorization. Yes, that's true. That part is true. But what we can say is across the world, the Pfizer and Moderna vaccines especially have now had millions and millions and millions of recipients with very few issues. And even the J&J and the AstraZeneca one, again, 1 in a million is an incredibly low side effect profile for any kind of serious complications. 1 in a million. That is so much better than any other drug that's sitting in your cabinet. It's better than Naprosyn. It's better than Motrin. 1 in a million for a serious side effect is remarkable.
Gene asks, if during the original trials, both the placebo group and the vaccinated group were wearing masks and social distancing, how do we know how much of the protection was due to the vaccine being tested?
Yeah, so let's take that one on. So here's what we know. In our hospital, where people were wearing masks, we would still have about 25 new COVID-positive patients from our own employees every day. Now, that's a pretty high number, and over a period of days, we have 100 or 100 people out with COVID-19 at the height of the crisis. Now that we have been vaccinated, how many people do we have out? 0, maybe 1. We don't have it anymore. So it's clear, even in our own story right here, that wearing a mask and getting vaccinated is the best possible protection. We also know that our employees, when they go home, is where they were getting they weren't getting it here at KU. We know this, so we know that masking works. But we know that you don't wear your mask all the time. And so when you take your mask off, you're just as susceptible. How do you prevent that? It is absolutely clear, without question, that people who were that took the vaccine didn't get the disease, and they didn't get sick from the disease, even if they got it. So remember also that both the people in the placebo group and the vaccine group were wearing masks, and the people who got the vaccine didn't get it. The people who didn't get the vaccine still wearing masks. They still got COVID, and they're the ones who had hospitalization and death, not those who had the vaccine. So there's absolutely no question the vaccine helps. Other thoughts?
Yeah, if I'm just misunderstanding the question, but if you control for all of those other variables and the only difference in those groups is the variable of getting the vaccine or not, then you attribute getting the vaccine to protection from getting symptomatic disease, hospitalization, severe disease, and death.
All right, Betsy suffers from adrenal insufficiency. She was holding out for the J&J vaccine because some adrenal insufficiency patients have had adrenal crisis from the second shot of the RNA. She goes, what do I do now? Which vaccine should I get?
What do you think, Hawk?
Yeah, I mean, I haven't seen those reports. I actually went back and looked, just as you stated, they are still studying these vaccines, and the VAERS reports are still coming out. They're published. There was one published a couple months ago in Morbidity Mortality Weekly Report, the CDC publication. So they are still looking at those, and those are publicly available. But I even looking through that report, I didn't see that adrenal crisis was done. I would, again, this goes back to your specific medical team, and I would discuss that with them. I don't necessarily see a mechanism for that either. So I really think talking with your endocrinologist is going to be an important thing to do. But I would still say that these are probably still safe to be able to get.
I think the best vaccine is the one you can get. I would go get that vaccine. If you are concerned about it, absolutely talk with your endocrinologist if you have adrenal insufficiency, or your primary care doc, but probably your endocrinologist. And in that situation, you may want to get monitored a little longer and we do monitor some patients longer than
And we
others.
can certainly look for reports on that, but I haven't noticed that. But.
Lindsay and Emily are both asking, can we just get one shot of Pfizer or Moderna? Is there any research? Do we still have to get two?
Okay, we're going to have a little fun with this. So, you want complete protection or nearly complete protection? I'd say take the complete protection. So let's say, what do you think about one-shot regimens for Pfizer or Moderna? Hawk, I'll start with you, then Kat, I'll come to you. Dr. Satterwhite, sorry.
Yeah, I mean, I think initially in those FDA briefs that they presented to the FDA with all their data, yeah, you absolutely start to see a change in those curves of the people that got the vaccine versus those that didn't, and those that got the infection probably at about 12 to 14 days. But we know from those studies as well that you continue to have an increased or more robust immune response and a longer or more durable immune response from that second dose. And so that's why you really do need that second dose of the Moderna or Pfizer vaccines.
And it did show, I think, in some populations, I think they were published in letters to the editor of the New England Journal 2 or 3 weeks ago, saying that 80% effectiveness after one dose, 90 to 95 after 2 doses, 80% after one dose of Pfizer and Moderna is better than J&J's one dose. So, thoughts about that?
You know, I think from my perspective, we recommend that everybody complete the vaccination series for the shots that they're getting. That is what the data that were submitted to the FDA are based on. And just from a larger perspective, that we all need to be doing everything that we can to help end this pandemic. And part of that is getting that second shot.
And I think we have better data now, too, about the efficacy against particular variants. And so I think, providing that second or that boosted dose to really help that specific immune response with the B cells and the T cells to really ramp up, I think is going to be important, because we know that the variants, in particular B117 or the UK variant, is becoming more dominant in the United States as well. So I think it's important to really try to protect yourself and get optimal immune response with getting that second dose of vaccine from the variants so far that we know about.
Steve wants to know, has the CDC guidance on vaccine for cancer patients changed? And if a cancer patient is having trouble with the vaccine, whose responsibility is it to report it? Is it the doctors, or do they have to navigate that as well?
Let's start with that kind of question first.
Yeah, so let me answer the second part first. So this, I think, is important to understand. VAERS, that we've talked about quite a bit this morning, and I know it's come up, is the Vaccine Adverse Event Reporting System. That system, anybody can report into. It's okay if things get reported more than once. So that is a system that the public can own and providers can own. So I just want to make sure that that's clear, but I'll turn to you. I'm not aware of any CDC changes.
No, and also correct me if I'm wrong too. VAERS, they are investigated, aren't most of those investigated as well?
So there are a number of people who track, who review every submission into VAERS.
Yeah.
And not every submission is investigated. There are millions and millions of reports that go into them. But yes, they are highly scrutinized.
And then I think as an individual, you can also download the app, the vSafe as well, specifically for COVID-19.
Yeah, which I would actually encourage, if you get vaccinated, even if you've already gotten vaccinated, if you're not too far out from your vaccine, please enroll in vSafe. It's a really excellent additional way that the federal government is trying to look for any adverse reactions, any problems after you would get a second dose, or first or second dose, depending on the series that you're doing.
Yeah, and I'm not aware of any new guidance for cancer patients. You know, if you were taking any immunosuppressive drugs or going to be getting chemotherapy, we would certainly recommend you get the vaccine. Now, you may not be able to get it while you are in the midst of your active chemotherapy, because the biggest concern there is that the vaccine would not create an immune response because you don't have those immune cells because they're knocked out by the chemotherapy. But as far as safety, you're still going to be safe to get it. And again, this goes into the detail of what exactly is your cancer, what kind of treatment regimen are you on, if you've had a stem cell transplant, where are you in that course. So it's really important to talk with your medical provider about it. But overall, the chance that you are going to be have some benefit from it is much greater than any risk of safety from it. So overall, no change in guidance. You probably should still be getting if you're cancer. It's just going to matter of what parts you're in as far as chemotherapy or anything like that.
Last question.
Last question? Okay. Carrie wants to know, she said, I've read that if I've had COVID, got my first dose, I don't need to get the second. It would actually be a waste.
Oh, it's definitely not a waste. You want that second dose because you want that added protection. I think your point about the variant was a great one because we know that you need to take a little higher titer, and the titer may not be quite as good against especially the B351 variant, and so, which is South African. But I think that in that situation, it looks pretty good that second dose probably gives you enough protection to help you.
Yeah, I mean, good reports out now about people who've just had COVID-19 versus those that got vaccinated. Certainly the people that got vaccinated had more robust immune response to COVID-19 than those natural infections. That's a good point about I had COVID-19, I got vaccinated. We do have good data that you have a more robust immune response after that first dose. But again, the guidance is still to get that second dose because we still don't know what will happen and how long you will have that immunity if you just get one dose even after having COVID-19. But certainly if you've had it and you've gotten Moderna or Pfizer, please go get that second dose to help with, number one, the robust immune response, but also that durability and how long that immune response will last to help protect you against, especially what we see coming up is the variants.
Hey, tomorrow we have a pretty interesting program. We're going to talk about prom and graduation. Now, I haven't had to have that discussion for a long time, but there are a lot of folks who are concerned about this. So Dr. Candy Southwick, who's the Executive Director of the Cooperating School Districts of Greater Kansas City, will be here, along with Dr. Jill Gilhouse and Nicole Kirby. Dr. Gilhouse is the Director of Secondary Schools for the Shawnee Mission School District, and Nicole Kirby is the Director of Communications for the Park Hill School District. So that'll be a very interesting conversation. We'll talk a lot about COVID-19, prom, graduations. Final thoughts.
Thank you again for all you guys doing the hard work. Please keep wearing masks. Please keep looking to CDC for existing and hopefully new recommendations as they are developed.
Yeah, you know, I think everybody should take comfort in understanding that there is a significant amount of transparency here. We want to continue to be transparent. That's what this pause was for. Investigate, get all the details, and then in a transparent manner present it to the public to continue to understand that this whole process of creating these vaccines has continued to be done in a safe manner, because there's nothing more important than safety, and this pause would be one more step to help prove that.
You know, I remember when we first started talking about getting vaccination, I think we said game on. And, you know, everybody loves, I love the Chiefs, I love the Royals, love sporting. But the vaccination, we said that's our first chance to go on the offensive, because we'd only been playing defense with masks, et cetera. And defense works, it wins championships. But it takes both sides of the ball. And in this situation, vaccination is so remarkable that was like Patrick Mahomes. But even Patrick Mahomes can't play the game without an offensive line. Otherwise, you have to run for 497 yards behind the line of scrimmage. That's tough. Don't be in a situation where you haven't taken advantage of all the things you got to do to win the game. Win the game, win the moment, get your shot. It's a call to arms. That's what's going to help us get back to normal. That's what's going to help us get back to the things that we want to do. Don't let fear rule your life. And the fear of COVID-19 is much greater than the fear of vaccination. We have had millions and millions of people. We've given over 70,000 doses here at our health system alone. The vaccines we are giving are safe, and they will only work, truly only work, when they are in you. There are three ways to make an appointment. One, go to MyChart if you're one of our patients. Two, if you're not one of our patients, or if you don't do MyChart or you can't get online, call 913-588-1227. Or if you're not one of our patients and you just want to go online, go to kansashealthsystem.com/vaccine. We'll get you taken care of, because you know it's all about that arm you have. It's about that heart. It's about your life.
I think we ought to also mention we have 300 Moderna doses out in Barton County.
All right, there you go.
So.
More good news. We can do this, folks. Let's get it done. We'll see you tomorrow.